Hello everyone, welcome to the case 10 of this Osce series. See, here we have a 50-year-old female who presents with complaints of breathlessness since the past 3 months now. There is no history of smoking and she doesn't have any primary carcinoma. So based on the CECT image, lung window axial section that has been provided, what do you think the diagnosis is? I'll give you some time to appreciate the findings. So on this image, what we can see are there are patchy areas of ground glass opacities that are seen on these axial sections in bilateral lung fields. Along with that, there are multiple small nodules that are seen. I have another image, axial section. This is the lower section, lung window, where again we can see multiple nodules and mosaic attenuation of bilateral lung fields, that is ground glass opacities as well as hypodensities. So on expiratory scan there was air trapping that was present. So based on this particular finding, what do you think the diagnosis is in this patient? Multiple nodules in bilateral lung fields with basal predominance along with mosaic attenuation in bilateral lung fields. So there are numerous well delineated intrapulmonary nodules and micronodules present throughout the lung with diffuse ground glass opacities with areas of air trapping on the expiratory scans suggestive of mosaic attenuation seen in bilateral lung fields with lower lobe predominance. So based on these findings, the diagnosis is DIPNEC, that is diffuse idiopathic pulmonary neuroendocrine cell hyperplasia, which is an extremely rare but underdiagnosed pulmonary disorder at the benign end of the neuroendocrine cell proliferation spectrum of the pre-invasive lung lesions. The diagnosis can be suggested when CT demonstrate characteristic findings, including multiple bronchocentric nodules as well as mosaic attenuation, which was seen in this particular case. So coming to all the differentials for DIPNEC, that will include all the conditions that are that present with multiple nodules in bilateral lung fields. Starting with pulmonary adenocarcinoma, it will show growth. The nodules will show growth over a period of time on serial imaging in pulmonary adenocarcinoma, and they'll be irregular in shape and of subsolid attenuation. While these nodules were quite regular and were of solid attenuation, and then there will not be any mosaic attenuation that will be seen. Hematogenous mets or infections, again metastatic lung carcinoma will have a primary and in this case there was no primary. Secondly, all the nodules in metastasis are of variable size and have a predilection for lower zones. Plus there'll be no mosaic attenuation as such seen in metastasis. Follicular bronchiolitis usually is associated with connective tissue disorder like Sjogren's and rheumatoid arthritis. Pulmonary hypertension is a good differential. If you diagnose that, you have to look for pulmonary artery as well, the diameter of the pulmonary artery compared to the aorta, which was normal in this particular case.